Hey everyone, welcome back to Static Cardiology here on EMTV. I'll be giving you an ECG rhythm and a scenario. On the bottom of the screen, you'll see a timer for 1 minute and 30 seconds. This time closely resembles the average amount of time you'll want to be spending on each card during an actual National Registry exam. When the time is up, we'll go over the rhythm and get the diagnosis, and then I'll give you my treatment. Enjoy the card, and good luck.
3, 2, 1.
Now the rhythm presented here is actually very subtle, and it's often missed. Let's go ahead and take a look at it in a little bit closer detail. Now the first thing I do when I'm identifying a rhythm is I count the rate. I'm counting 5 QRS complexes. I then like to identify the PR interval. Now this PR interval is actually very long, because I know one of these larger boxes equals 0.2 seconds, and then each smaller box represents 0.04 seconds. If I add them up, this PR interval looks to be about 0.28 to 0.3 seconds. Now, as the normal PR interval for a sinus rhythm is between 0.12 to 0.2, this appears to be an AV block. My R to R intervals also seem very consistent, and there are no dropped QRS complexes. There is also one P wave present for each QRS. Because of this, my diagnosis of this rhythm is a first-degree AV block. Now, let's go ahead and take a look at the scenario to determine whether or not this rhythm is stable or unstable. You were dispatched to a restaurant for a 73-year-old male in cardiac arrest. Upon arrival, you find the patient lying on the floor, unresponsive. Bystanders report that they witnessed the man collapse and immediately began CPR. An AED was attached and 3 shocks were administered successfully. The patient does not appear to be breathing adequately, but you are able to palpate a slow, weak carotid pulse. Your partner obtains the following vital signs: blood pressure 58/30, pulse 50, respirations 4, SpO2 87% on room air, and a blood sugar of 118. You attach the monitor and obtain the ECG above. In order to provide proper treatment to this patient, you must first make the determination if he is stable or unstable. For determining instability, I use the acronym CHAD. And this, of course, stands for cardiac insufficiency, hypotension, alteration in mental status, and dyspnea. Based on this patient's presentation as well as his vital signs, my final diagnosis for static cardiology is going to be an unstable first-degree AV block. Now, let's go ahead and move on to the treatment. Just like with all my other cards, I'll begin treatment by regurgitating the mantra, Scene Safe, BSI, IV, O2, Monitor. Now, this patient is in a unique situation. He was in cardiac arrest, but he's achieved ROSC, or Return of Spontaneous Circulation. Treatment for a patient who's obtained ROSC will involve optimizing and stabilizing the ABCs, getting a 12-lead ECG, and then, depending on mental status, therapeutic hypothermia or targeted temperature management. For this patient, because they're not breathing effectively, we'll go ahead and secure the airway and provide ventilations with a BVM. And as this patient is bradycardic, we'll go ahead and attach the pads and turn on the pacer. I'll select a rate of anywhere between 60 and 100 pulses per minute, and then increase my milliamperage until I achieve electrical and mechanical capture. Checking the patient's carotid pulse assures mechanical capturing. At this point, I could then consider administering vasopressors, such as norepinephrine, given at 0.05 to 0.15 micrograms per kilogram per minute, or dopamine, given at 5 to 20 micrograms per kilogram per minute. I'll obtain my 12-lead ECG, and because this patient is unresponsive, I'll go ahead and begin targeted temperature management, or formerly known as therapeutic hypothermia. Pre-hospitally, I could stick ice packs around the neck, under the arms, and near the groin to reduce core body temperature, but in the acute care setting of the hospital, I'll use a device like the Arctic Sun to achieve lower core temperature goals within that 24-hour period following arrest. This is done to preserve brain function. Studies have shown that patients do better neurologically after receiving targeted temperature management following a cardiac arrest event than patients who did not receive targeted temperature management. In the hospital, we'll also perform an EEG and monitor the patient for seizure activity. But since we're pre-hospital at this point, the last thing we'll do is rapid transport. And that's it. If you enjoyed this card, please make sure to head over to my channel for more. And while you're there, check out my other playlist, Static Pharmacology. Thank you so much for liking and continuing to support my channel, and make sure you hit that subscribe button below. Until I see you next, stay safe, keep washing your hands, and have a good rest of your night.